Hello, and welcome to Managing Myeloma. Today we are pleased to present the Grand Rounds discussion entitled The Multidisciplinary Team Approach, Managing the Newly Diagnosed Patient. My name is Sir Giralt, and I am the Service Chief of the Adult Bone Marrow Transplant Service at Memorial Sloan Kettering Cancer Center. I am pleased to be joined by my colleagues Donald Harvey, Assistant Professor of Hematology and Oncology at Emory University School of Medicine, and Beth Faiman, Nurse Practitioner at the Cleveland Clinic. The goal of this educational activity is designed to provide practitioners with the safety and efficacy data for new systemic therapies for use in this patient population. In addition, we will examine opportunities to safely select and integrate these therapies into individual patient treatment plans to ensure improved patient outcomes and quality of life. As a reminder, this program is accredited for 1 hour of continuous education credit for physicians, pharmacists, and nurses. In order to receive credit and print your certificate, you must view this presentation, successfully pass the post-test, and complete the evaluation assessment. Few diseases have had more changes in therapy than multiple myeloma in the last 10 years. With the advent of immune modulatory drugs such as lenalidomide and thalidomide, the discovery of the proteasome inhibitor bortezomib, and the development of effective combinations combining alkylating agents, immune modulatory drugs, proteasome inhibitors, and steroids, we now have effective therapies that can induce responses in more than 70% of the patients. Myeloma therapy now consists of induction therapy, which is a combination of the agents I've already mentioned, consolidation therapy in transplant-eligible patients, and most recently, the development of maintenance strategies that can effectively prolong remission durations. We've also been blessed because of the development of novel therapies that can be used in the setting of patients relapsing after primary therapies. The challenge for patients, for physicians, for nurses, and for PharmDs is how do we put all these strategies together to give patients the longest life with the best quality of life with the minimum burden of treatment. The other challenge is that the average age of myeloma patients today is over 70 years. These patients have multiple other comorbidities, or an average of 2 or 3 other drugs, which can actually have important interactions and important drug-drug interactions that need to be taken into account when treating these patients. Thus, a multidisciplinary approach is essential for the appropriate treatment of multiple myeloma patients today. The team is included not only by the physicians, but other healthcare practitioners such as nurses, nurse practitioners, physician assistants, and PharmDs, which are essential for the safe delivery of these very complex chemotherapies, not only in the academic centers, but also in community centers. Let's talk about a typical presentation. This is a 45-year-old who presents with kappa light chain myeloma. She has 5 grams of urine protein with bench shown at around 3 grams. Her creatinine is 1.7, her beta-2 microglobulin is 4.7. She has no paraprotein peak in the blood, but her light chain is around 120,000, which gives her a very elevated kappa lambda ratio. Her bone marrow shows 80% cellularity with 25% plasma cells, and her cytogenetics do not show any high-risk features, although she has an invasion 9 with a P11Q13. Fluorescent C2 hybridization shows no abnormalities. Skeletal survey and MRI shows bone disease, but no areas of risk of fractures. Importantly, she's a diabetic. She's been on metformin, but she has no other history of coronary artery disease or other comorbidities. How should we treat these patients? What are her risk factors? Is she a candidate for transplant? What special considerations should we take in the patient based on her comorbidities and her disease characteristics? So let's remind ourselves that the goals of induction therapy for all patients is 1, to achieve a rapid response in the myeloma and prevent further end organ damage, particularly protection of kidneys and protection of the bones. We want these responses to be durable, and we want them to be deep, preferably achieving a complete remission. The goal is to improve the performance status. We need to prevent stem cell damaging, and that's why melphalan is not recommended in transplant-eligible patients because of damage of stem cells. So Induction therapy is targeted to get a rapid response in the myeloma, a deep response while preserving stem cell function. There are a lot that we now do not know regarding induction treatment. What are the best combinations? Can we risk stratify? Is a patient with Duri-Salmon 1 or ISS 1 treated the same as a patient with a Duri-Salmon 3 or ISS 3? Are patients with renal dysfunction needed to be treated differently than patients without renal dysfunction? How many cycles of therapies are needed prior to stem cell collection? How many cycles of therapy are needed prior to stem cell transplantation? Should we do a fixed number of cycles, or should we continue to treat patients until they've had a plateau phase? We do not know the answers to many of these trials, but I think there's some things that are now being clarified by the phase 3 trials that are currently being reported. Although we recognize that myeloma is not one disease and that there are multiple myelomas that are characterized by different cytogenetic abnormalities, as of 2012, we still treat patients during induction therapy with the same drugs regardless of what the cytogenetic abnormalities is. I think the changes are coming is what types of maintenance therapy and what type of consolidation therapy, particularly patients with poor risk disease, should get. Those with deletion 17, 414, or 1416 translocations. Although many of us would like to reduce the burden of therapy, it is still uncertain that less intense therapy for patients with standard risk disease will actually translate into better outcomes. And until those randomized trials are done, we recommend that the optimal induction therapy be done in all patients regardless of their risk category. So what is the optimal induction therapy in the year of 2012? There are a variety of randomized trials that have looked at the question of bortezomib-based induction versus non-bortezomib-based induction. This is the trial from Cavo et al. That was published in Lancet Oncology, looking at the introduction of bortezomib at the traditional dose of 1.3 milligram per meter squared on days 1, 4, 8, and 11 in combination with thalidomide dexamethasone. Patients were randomized and then would receive consolidation therapy with tandem autologous transplant losing melphalan 200. Those randomized to the bortezomib arm would get consolidated with another couple cycles of bortezomib thalidomide dexamethasone and then would go on to maintenance steroids. This trial, together with the French trial, showed that the addition of bortezomib as part of the induction therapy not only significantly increased the responses of patients prior to transplant, but actually translated into a significant benefit in progression-free survival post-transplant. As you can see in these curves, for patients who received bortezomib as part of the induction, the progression-free survival was significantly better, upwards 70%, to those who did not receive it, as opposed to thalidomide dexamethasone. This trial did not show a survival benefit, however. This benefit was seen not only in the patients who achieved less than a complete remission prior to transplant, but even in patients who achieved a complete remission. Thus, at the 5-year landmark analysis, this trial confirms that patients receiving bortezomib during induction treatment had a better post-transplant outcome, although survival was not different. Regardless of the cytogenetic abnormality, there was a benefit in adding bortezomib. So even patients with standard risk cytogenetics had a significant benefit in the addition of bortezomib during induction treatment. Multivariate analysis showed that the single most important factor for long-term disease control was being randomized to the bortezomib-containing arm. What price did patients pay for going on bortezomib? Peripheral neuropathy was a significant side effect. I remind you that in this study, bortezomib was administered at a dose of 1.3 milligrams per meter squared twice a week intravenously. And as we'll discuss later, there are alternative strategies to administer bortezomib which may result in a significant reduction in the risk of peripheral neuropathy. Patients getting bortezomib also had higher risks of getting thrombocytopenia and other hematologic toxicities. But in general, the addition of bortezomib to thalidomide dexamethasone was well tolerated. In the American Society of Hematology meeting last year, Nuka et al. Presented a meta-analysis of all the studies looking at bortezomib-containing induction regimens versus non-bortezomib-containing induction regimens. Despite that no individual study showed a survival benefit, the meta-analysis showed a significant overall survival benefit when all 4 trials are combined. I think all these trials suggest that in 2012, induction therapy for myeloma patients who are undergoing autologous transplant should include bortezomib. In North America, lenalidomide, bortezomib, dexamethasone has been touted as the myeloma CHOP, based on work from Paul Richardson et al. At the Dana-Farber Cancer Institute. This again is a very well-tolerated regimen. Lenalidomide is administered 25 milligrams daily, bortezomib 1.3 milligram per meter squared, 1, 4, 8, and 11, and dexamethasone the day of and the day after bortezomib at a dose of approximately 20 milligrams a day. 100% of patients responded, with almost 50% of the patients achieving a complete remission. This is without doubt one of the most powerful induction regimens that has ever been published for myeloma today. Luskin et al. Reported at ASH this year, of 480 patients who underwent an autologous transplant, 80 of them had received at least 2 cycles of lenalidomide, bortezomib, dexamethasone. Patients were able to receive a median of 5 cycles of lenalidomide induction, and most patients actually went on to transplant. Only 10% of the patients were unable to receive all 3 drugs due to drug toxicity. After transplant, 30% of patients were able to achieve a further reduction in their tumor burden. All patients were able to be collected successfully. And interestingly enough, a significant proportion of patients opted not to proceed to early transplantation because of their dramatic response to lenalidomide, bortezomib, dexamethasone. Although not a randomized trial, these patients seem to be doing as well as patients who opted for transplant consolidation. So let's go back to our patient. She begins treatment with bortezomib 1.3 milligram per meter squared, sub-Q, day 1, 4, 8, and 11, with dexamethasone 20 milligrams, day 1, 2, 4, 5, 8, 9, 11, and 12. And then lenalidomide given 25 milligrams daily the first 14 days of the cycle. 3 weeks afterwards, she appears in the emergency room with a neutrophil count of 1,000, a platelet count of 75,000, a glucose of 300, and a creatinine of 2. She's admitted because she has fever and is somewhat disoriented. I'm now honored by having 2 experts in myeloma therapy from the non-physician area. I have Dr. Don Harvey from Emory University, a pharmacy specialist, and Beth Faiman from Cleveland Clinic. I wanted to ask both of you, this is a typical induction patient, and I have to say the problem that she faced is a problem that I have seen faced before. From the PharmD perspective, do you think with her creatinine of 1.7, her lenalidomide should be dosed like that?
Well, certainly she had hematologic toxicity, so that tells us that we should have thought more carefully in the initial setting of her lenalidomide dosing. And lenalidomide's 2/3 cleared by the kidneys, so in patients with creatinine clearances below 60, certainly a dose reduction from 25 should be done. I think one thing we also need to remember is that in patients who have myeloma-induced renal disease, going back up on the dose after their creatinine has hopefully normalized, although in this case it did not, certainly needs to be kept in account.
Mm-hmm. Beth, as a nurse practitioner, if, let's say I wrote those orders and I had not written for hematologic follow-up of that patient, would that have caught your attention, and would you have told or requested, look, we need to actually bring this patient in more frequently to check her counts?
Absolutely, and that's an important consideration. Nurses are really integral to the follow-through with the patients. You have a busy clinic and a lot of responsibilities. The recommendations for patients who receive lenalidomide and dexamethasone only would be checking blood counts weekly for the first 8 weeks of therapy. However, she's also receiving bortezomib. That means the myelosuppression is going to be a little bit greater. So with each dose of bortezomib, I would have recommended and then followed through and ordered that for this patient.
How about the administration of bortezomib, intravenous or sub-Q, particularly now people are being challenged by the fact that the data for sub-Q is primarily in the relapse setting. Should we look at that sub-Q data and say it will protect patients from neuropathy in the frontline setting? And should we all be adopting these alternative ways of administering bortezomib?
I think certainly the subcutaneous route makes a lot of sense. It's much more convenient. While the PK is slightly different, the neuropathy appears to be reduced with subcutaneous administration. It's much more convenient for patients. My expectation is that moving sub-Q administration from the relapsed into the upfront setting would lead to very, very similar results.
Beth, this patient was a diabetic. She was on metformin. She comes into the emergency room with a glucose of 300 after getting high-dose steroids. What are the nursing implications of this? What can we do to prevent this from happening? What education piece do you think is essential when we start our patients, particularly our diabetic patients, on steroids for their treatment of their myeloma?
Absolutely. Patients with diabetes oftentimes know their diagnosis. The group that I try to identify are those that have been told that they've had high blood sugars in the past. This one, we knew she was on metformin, she was overweight, and she had that history. So I would try to tighten up her diet, carbohydrate-controlled diabetic diet, and I would also try to make sure she's in tight collaboration with her primary care practitioner, endocrinologist, or whoever manages her diabetes, checking her blood sugars. This is integral to the nursing education piece of the side effects of therapy as well. I think we oftentimes overlook steroids and the education, such as the mood swings, the hyperglycemia. So definitely checking her blood sugars, watching diet, and weight loss as well.
Don, metformin is very commonly used as an anti-diabetic agent, has renal problems. In this patient with a creatinine of 1.7, would you have changed the treatment? How would you have handled the diabetes? Or what would you have suggested the physician to do for the diabetes?
I think when you look at her renal function, she's diabetic. So the question is this renal function due to her myeloma alone, or is it potentially the beginnings of diabetic nephropathy and thus concerns there? I mean, metformin certainly has more toxicity in people with renal dysfunction. In her, going on steroids, thinking about her entire blood sugar management as best suggested, perhaps it would have been better to go ahead and place her on an insulin-based regimen, pretty frequent monitoring of her blood sugars to ensure that we didn't run into a problem with hyperglycemia leading to, along with other things leading to a hospitalization ER visit.
So to both of you, most community physicians don't have great nurse practitioners and don't have a PharmD at their beck and call just in case to advise them. From the physician standpoint, there are a lot of resources that physicians can use to be able to be up to date in myeloma. Managing myeloma is one of them. NCCN guidelines. What does your professional society, or what resources do you think a community physician could access to be able to get your type of expertise to handle their patients?
No, I think there are a few organizations out there. The Hematology Oncology Pharmacy Association, certainly we're trying to improve education and awareness of pharmacists as a profession. But myeloma-specific resources like this website, certainly product information can be helpful. NCCN guidelines are helpful, and other foundation-based websites that really deal directly with patient management on a day-to-day basis can be, I think, very, very helpful for folks without the resources that many academic centers have.
Beth, what about for, again, small community practice, maybe sees one myeloma patient a year, is now dealing with this patient? What do the nurses in that practice, what resources would they have to help take care of the patient from the nursing perspective?
I like to recommend the managingmyeloma.com as well as the NCCN guidelines, as you'd mentioned. However, the patient care organizations, International Myeloma Foundation, Multiple Myeloma Research Foundation, and not to forget the Leukemia and Lymphoma Society, they all have a breadth of services available, from financial to the social to the chat rooms. And so the nurses in the community and the physicians should be aware of those resources and direct the patients to them as well.
And as I always tell them, all of us in the myeloma community are always willing to help any patient or physician who's taking care of this. So let's see what happened to our patients in the next cycle.
Of course.
So based on her experience during the first cycle of induction therapy, our patient now undergoes cycles 2 and 4 with dose-attenuated lenalidomide at 15 milligrams a day, dexamethasone 20 milligrams now given only the day of bortezomib, and bortezomib at the same dose of 1.3 milligram per meter squares on day 1, 4, 8, and 11. She's been seen by an endocrinologist and is being followed by a diabetic nurse with perfect control of her blood glucose during all monitoring. After 3 cycles, she's now of no problems with ANCs of 1,500 at the time of nadir. She now goes for stem cell mobilization and potential transplantation. The role of transplant in the era of new combination induction therapy is now again needs to be re-explored. This patient has achieved a very good partial response with the kappa light chain reduced to 10 and lambda light chains recovered to 0.1. Her marrow reveals 4% kappa restricted plasma cells. MRI shows a significant resolution of infiltrative image. And although she agrees to proceed to stem cell collection and transplantation, it is important to recognize that this decision is no longer easy. We need to remind ourselves that most of the randomized trials that show a benefit for early versus late transplantation were performed prior to the advent of bortezomib and lenalidomide. We also have to remind ourselves that most of these trials showed a significant benefit in progression-free survival, and 2 of them showed an overall survival benefit. High-dose melphalan with autologous stem cell support is one of the most single active agents in myeloma today, with a complete remission rate of around 30%. However, the decision of proceeding to transplant early versus late needs to be re-explored. 2 randomized trials are currently being performed, one with the IFM and the Dana-Farber, and another one the European Myeloma Network. However, until the results of those trials are published, we believe that transplant therapy should be offered to all transplant-eligible patients as part of consolidation therapy. Although we understand and we recommend when we advise patients that transplant's a choice, it's not a necessity. It's a choice patients make based on the recommendations of their physicians, based on the perception of what the natural history of the disease is. Again, transplantation, both pre and post, requires a multi-team disciplinary approach. I will now talk to both our nurse specialist and our PharmD specialist about the implications of having a multidisciplinary approach when patients approach the decision of transplant and stem cell collection. So, Don and Beth, our patient has undergone 4 cycles of chemotherapy. She has had a major response, long discussion about whether she should get transplanted or not, and she opts to proceed to high-dose therapy and stem cell collection. Her creatinine has stayed around 1.7. She was, as you recommended, placed on an insulin type of strategy. As she's getting ready for transplant, should she go back on metformin? What should we be doing with her diabetes?
I think looking at her diabetes as a whole, you'd want to ensure that her A1C was in good control and have a good diabetic care plan for her. I think it'd be reasonable to put her back on metformin. Certainly, creatinine of 1.7 is not optimal, but it could certainly be part of the mix, be more convenient, et cetera. And taking her through transplant and the transplant procedure, perhaps that's not, if she's to go shortly, perhaps that's not the best strategy because she'll probably have changes in blood sugars as she goes through the transplant process. But I think it's not unreasonable to consider going back on metformin for her.
Patients are always asking, what medications should they take, what medications affect or do not affect stem cell collection, being on aspirin, being not on aspirin. Any guidelines that you guys have in Emory as you take people through the stem cell collection process?
Yeah, certainly we've adopted the bortezomib, lenalidomide, dex-based induction regimens, and so our standard approach for the transplant-eligible candidate has been, first of all, hopefully clinical trial, but 4 cycles of that regimen and then collect and store. And certainly it's been shown that more cycles of lenalidomide lead to a reduced stem cell collection over time. So we try to collect early just to ensure that we get those numbers that we're looking to get.
Beth, no doubt, at least in my experience, the nurse practitioner is one of the most essential pieces as we take patients through the transplant journey. What recommendations or what, I would say, specific insights do you have for community physicians in a patient like this that's getting ready for transplant? What's the nursing perspective? How can we ideally educate patients for what's going on for them?
It's important to understand that the patient, and I think you so eloquently put it, this is a recommendation, not a necessity. In this day of age, we have options, but try to help them through that decision-making process is important. Showing the studies that illustrate the side effects, such as bortezomib peripheral neuropathy, we worry about that, increased risk of varicella zoster, so our patient should be receiving acyclovir, famciclovir, valcyclovir, whatever cyclovirs that work for them, as well as the side effects of lenalidomide, myelosuppression, and risk for venous thromboembolic events. So if they stay on these regimens, these side effects can be cumulative in some respects. If they do decide to go forth with transplant, fatigue is going to be a major issue, as well as the myelosuppression and infection risk during that transplant period. So that's where I think that the nurse and the physician, the pharmacist, and the social workers can work as a team to help that patient through that process.
I agree. I think a team approach, as we're seeing, is essential not only for the transplant-eligible patient, but for the transplant-ineligible patient. And I think both of you put as a factor that when we start these patients on these types of regimens, they also need to be on a whole set of other supportive care measures, not only to reduce their symptom, but to prevent complications such as herpes zoster, varicella zoster infections.
Yeah, and I was just going to point out, we didn't even touch base upon bisphosphonate use, and again, I think later on in this we'll discuss more of the supportive care measures that are essential.
Correct, and I think that's the other reason why it's important to have a multidisciplinary team approach and follow an algorithm. The bisphosphonate is a perfect example of something that the PharmD needs to be helping the physician monitoring renal function to be able to make sure that the appropriate dose is given. The nurse needs to be heavily involved to make sure that these patients are doing adequate dental care, which has been associated with significant reductions in osteonecrosis of the jaw. So I think I want to now take you very quickly through the transplant journey and what it entails in regards to symptoms and side effects. And then we're going to conclude with what I think now is probably the most controversial, but yet the most practice-changing aspect of myeloma care, which is continuous therapy. The patient decides to proceed to stem cell transplantation. And although not the object of this specific activity, I think it is important to remind people what the 5 phases of transplants are and the significant side effects and symptoms that patients can undergo through this period. So after stem cell collected, patients usually get phase 1, which is high-dose chemotherapy. Currently, the most common conditioning regimen in myeloma today is high-dose melphalan. The cells are infused, and this marks the beginning of phase 2 of the transplant, the cytopenic phase. This is the phase where most patients feel the worst symptom burden. This is the time when they get the gastrointestinal toxicities of the high-dose melphalan, such as the nausea, the poor appetite, and sometimes severe diarrhea. Usually within 10 or 14 days, patients' counts have recovered, and this marks the early recovery phase, which is a transition phase. This is the phase where a multidisciplinary approach is important to avoid readmissions and to make sure that patients are well educated on the medications they need to be taking to prevent late transplant infections and to be able to minimize the late side effects that happen after transplant. The 4th phase of transplant usually is the first 3 to 6 months after transplant, early convalescence. This marks significant changes in lifestyles. Patients are advised that their immune systems remain significantly immature. They need to take medications to prevent pneumocystis pneumonia. They need to take medications to prevent viral reactivation. They need to continue to be monitored carefully either by their primary oncologist, their primary internist, or their transplant specialist. After 6 months, patients enter late convalescence, many times marked by reimmunizations, which is essential for our transplant patients because it cannot be guaranteed that the vaccines they got when they were children were actually transferred. After the transplant process, even when patients have recovered their counts, the most significant symptoms that patients complain of is fatigue. Fatigue has become an important aspect where we're trying to reduce to be able to minimize the burden of therapy of stem cell transplantation. In other activities, we will talk about the reduction of symptom burden in transplant. Our patient underwent an autologous stem cell transplant without complications and achieves a complete remission without evidence of kappa-restricted plasma cells in bone marrow, a negative immune fixation in blood, and urine in normal kappa-lambda ratio. MRI shows almost complete normalization of her infiltrative lesions, and she now asks the question of maintenance and consolidation. 2 trials recently reported in the New England Journal of Medicine have shown that post-transplant lenalidomide continuous therapy is associated with a significant improvement in progression-free survival. The IFM trial, reported by Attal et al., showed that this benefit is seen even in patients who have achieved a major response to induction therapy, such as a VGPR or a CR. The impact of the benefit is dramatic. In patients who have achieved a partial response or stable disease, the median progression-free survival on lenalidomide maintenance is beyond 3 years. while the median progression-free survival for patients on placebo was less than 2 years. For patients with major responses to induction therapy, the median remission duration has not been reached, as opposed to approximately 3 years for patients on the placebo arm. Thus, regardless of the response, this trial suggests that lenalidomide continuous therapy is associated with a benefit in long-term disease control. Similar results were reported by McCarthy et al. In the same issue of the New England Journal of Medicine. Patients on lenalidomide maintenance had a median progression-free survival of approximately 42 months, significantly better than the 24 months in patients getting placebo. Of interest, patients who received induction therapy with lenalidomide and then went on to transplant, followed by lenalidomide post-transplant therapy, have a progression-free survival that has not been reached, and 73% of them are alive without progression at the 3-year mark. These are results that have never been seen in myeloma therapy today and suggest that this may be the new standard of care. Nationally, we are performing a trial with the Blood and Marrow Transplant Clinical Trials Network, which looks at the different roles of consolidation therapy after transplant. This is a large 750 patient trial looking at, in the context of lenalidomide maintenance, is there any additional benefit of giving post-transplant consolidation with bortezomib, lenalidomide, dexamethasone, or is there an additional benefit of a second course of high-dose melphalan? This is a very important study. It is accruing very well, thanks to the support of all transplant centers and funding from the NHLBI, the NCI, and the NIH. I think what most myeloma experts are starting to agree is that response makes a difference. And achievement of a complete remission is probably the single most important surrogate for long-term disease control. The definition of complete remission in myeloma will also probably change. As we develop newer techniques to document minimal residual disease, such as flow cytometry or polymerase chain reaction, we may need to be changing our standards of treatment. But standards of treatments can only change with evidence-based medicine, which can only be done when all patients, physicians, and allied healthcare personnel support and encourage clinical trials. I'm now going to ask my panel what the impact of maintenance therapy and long-term continuous therapy has been on their practices and how the multidisciplinary team approach is essential to optimize long-term therapy with lenalidomide or other maintenance strategies. Don and Beth, I think you'll agree with me that lenalidomide maintenance has, jumped into the myeloma world. We've all been impressed by the dramatic results of both the IFM and the CLGB. We still have to be cautious about this. These are only 2 trials. Only one of them showed a survival benefit. But at least from my practice, I'm seeing that this is being rapidly adopted in the community. Do you agree?
Yeah, I think when you see that data and whenever you have 2 back-to-back papers in the New England Journal of Medicine, people tend to jump on it pretty quickly. And certainly lenalidomide maintenance makes a lot of sense. But there are some hang-ups with continued therapy as we've talked about. One is, we've talked about the issues of adherence. It becomes an issue as patients are on longer and longer, that as time goes on, patients tend to become less adherent. So it really does take physicians, pharmacists, nurses working together to maximize adherence to and access to these oral therapies.
Again, this is an older patient population on lenalidomide therapy for a prolonged period of time. Multiple of them will get more and more drugs. Are there any specific drug-and-drug interactions with lenalidomide that practicing physicians need to be aware of, particularly, some specific no-nos, or is it kind of safe to combine it with any antihypertensive or anti-diabetic medicine?
I think in general, you just have to think about what drugs are going to be renally cleared and what drugs may cause additional kidney damage if used chronically. Certainly these patients may have pain. They're older, they may have osteoarthritis, so nonsteroidals come right to the front of the mind in terms of both platelet inhibition, but also renal damage if taken in high doses for long periods of time. But certainly, as new medications are considered, careful consideration of adding drugs to lenalidomide or any drug for that matter is certainly important to make sure we do it safely.
Beth, for the nursing perspective, not only is it the added burden of Rev-Assist for all patients, which is it's our obligation to make sure that nobody on lenalidomide can actually get pregnant or leave somebody pregnant on it, but There are other very important implications, such as what does a patient do if they develop an upper respiratory tract infection? Should they stop their drug? Should they take their drug? How do you encourage patients to continue on this drug for their life? What has been, in your view, the most important nursing implications of continuous therapy with lenalidomide?
It is very important to illustrate this is not a benign drug. It's not like taking an aspirin a day, which that's actually not benign either. But speaking of aspirin, the anticoagulation aspect of it is what I think is important. They can be on lenalidomide for 5 months or 5 years and be fine, but then develop a venous thromboembolic event. So education of the risk of blood clots, unilateral swelling, respiratory symptoms, or signs of a pulmonary embolism is important. The other thing is, you had mentioned renal, Don. I think that once you prescribe the lenalidomide, what I'm finding is myelosuppression is a consequence of continued therapy, not only from being on the lenalidomide, however, the renal function can change. There's an intrinsic renal insufficiency in somebody with diabetic nephropathy, and then you have the myeloma aspect. So monitoring the creatinine clearance and reducing the dose long-term is also important. As far as adherence, we do calendars. I try to work with the specialty pharmacies to have them remind me when I need to remind the patient. And they need to have their blood counts checked every month, no question, to make sure that they don't develop myelosuppression while they're on the drug.
Second primary malignancies has become a very hot topic, and I think both trials showed that there was an increased risk of second primary malignancies, that although most of us feel that the risk is far outweighed by the benefit and improved disease control, it is also an important aspect for both PharmD and nursing perspectives. What would you think for the PharmD would be the best aspect in regard for second primary cancers? What would your role be in that education process?
I think the data is certainly out there. It's, to me, a little bit unclear. It's not completely finalized yet, but just to let patients know that it is a potential complication of continued lenalidomide therapy. But I think the more important part and more important point is what you just made, and that's that the benefit of this is listed in the trial, and the risk-benefit ratio will more than likely always come out in favor of continuing the drug. But just letting them know that it's possible. You can have skin cancers, you can have second primaries potentially again, but I think it's just something that patients need to understand as they go forward on maintenance therapy.
And this is essential nursing perspective too,
Yeah,
right?
and patients are living longer anyhow. I said to my patient the other day, I said, you've been on lenalidomide for 6 years now for your newly diagnosed myeloma. She says, I've seen grandbabies born, and I've seen all kinds of wonderful events. I'm living longer anyhow, so thanks for informing me. And this is what I take home. But it's important for the health maintenance perspective. Have a primary practitioner. You do the annual mammograms, the colon cancer screenings, prostate screenings. These are very essential pieces to this survivorship aspect of our patients are not dying after 2 to 3 years. They're living so much longer. So keeping up to date from the health maintenance perspective is critical.
Right, regardless of lenalidomide therapy or myeloma or
Blood
anything,
pressure,
certainly those
everything.
standard health maintenance issues do come into play.
And I think in closing, you've actually put that the other very important member of this team is the primary care practitioner who's taking care of these patients and your other aspects of healthcare, and they are an essential member of the team, particularly as we've said, these patients are now living a long and very productive life. So I want to thank you both. This has been a very interesting conversation. I think we will finish by recommending all of our audience to look at the NCCN guidelines, to look at trials.gov to find clinical trials close to them. Because as we said, the best way to advance cancer care is to participate in clinical trials. Thank you very much.